Yeah, so mesenteric stenosis today, um, maybe renal arteries next week, maybe not. The IVC, there's a little section on that in the book. I mean, that's almost a footnote. We could add that in, and actually the IVC really kind of comes into play with different things like renal artery or kidney tumors and how that affects the IVC. But so we'll fit that one in there as well. Anyway, today, mesenteric stenosis. So most people with mesenteric stenosis don't know they have it. But those who do, or those who suspect there's something wrong and they're losing weight and everything. Let's see, we're just going to call this mesenteric artery stenosis. And one of the things that people who have serious mesenteric artery stenosis is a fear of food. Now, they're not like running away in terror, thinking the food is going to come and get them. Their fear of food really is they feel horrible after eating. They feel very sick after eating. And this is every time they have a meal. And so they obviously, they start losing weight. They start eating very small meals. The less they can digest at any time, the less pain they feel upon eating. There's a couple of words in there in this chapter that I want to make sure we all know. One is a state of being, well, it's prandial, but let's do pre-prandial. And that's basically before a meal, before eating something. It's pre-prandial, and therefore obviously postprandial, what's this real quickly, is after a meal. And this comes into play because these arteries, especially the SMA and the IMA, they change their characteristics pretty dramatically, whether or not you're fasting state or whether or not you've actually had something to eat. This is very, very similar to what we see in the legs. A resting leg has a waveform that is very high resistance. But an exercising leg, and this happens in a matter of 2 seconds, the moment you start exercising your leg, doing calf raises, you go from a low resistance flow to a high, you go from high resistance flow to low resistance flow because your muscles need that blood. And the same thing happens in the mesenteric arteries, especially the SMA. And this little guy down here, and I draw him like this because that's, if you're lucky, that's about all you're going to see. If you see him at all, you're lucky. And beyond that, you're not going to see much more. So I am a, okay. So, and of course, this is my celiac trunk over here. Celiac trunk, celiac axis. And I always draw it cut off like that because coming towards us is the hepatic artery, going away from us is the splenic artery. And of course, we could see that down here. Here's my celiac trunk again, except now on a transverse view, we see the common hepatic artery. Let's go ahead and write that. Common hepatic artery comes towards us. And if we were to see that up here, if we were to see it, let's say we came just a little bit off center, or sometimes the celiac trunk goes right and then, you know, it's a little, it can be a little squirrely in there. And if we see a circle, say right about there, Well, it depends. That circle, this circle could be either the common hepatic artery or the splenic artery. Let's put a T there. The splenic artery as well. Just really depends on whether we're slightly to the left or slightly to the right. So I'll just, you know what, we'll call that the question mark artery right there. Now, so we're going to talk about Doppler of these, because it doesn't just do us much good to just simply look at these arteries. I mean, it certainly does. If you happen to see plaque, that's great. But Doppler is really the way we're going to examine these arteries. And let's go ahead and do a quick Doppler image. And then let's see if I'm going to have my angle correct here. See how I did my angle correct with the flow, with the artery. It's very important. And that angle correct is probably, if you're getting it right there, that angle correct is going to be well under 60, and that's fine. And that's actually good. If you're getting it back here, and then here's my angle correct along there, it's difficult to get that at 60 or below. And that's simply because it runs flat across the body. We're going to have to really heel toe that curved transducer. But in any case, a normal, let's see, we'll call it NPO. Whoop, I forgot I was in that mode. NPO slash pre. They more or less mean the same. NPO is you haven't had anything to eat. Preprandial is you haven't had anything to eat yet. So it's got a high resistance blood flow. Let's make sure I didn't miss anything right here. Sorry, guys. Come on, phone, just show me what you have. No, you guys all, according to corporate, yes, you actually do need to have your cameras on, but I'd be terrified to see what y'all look like right now. But you know, we're all happy to see JP. So. High resistance for the, I should let's make sure we know that this is actually the SMA waveform here. NPO or preprandial high resistance waveform, either no flow, or I could probably say, oh, well, maybe a little bit of flow. Either way, whether it goes down to 0 or almost 0, that's still high resistance. So either way we write the waveform is just fine. And then afterwards, let's see. Afterwards, let's draw it over here. Now we're going to look more like low resistance post prandially. I guess that's an A. Prandial, that's a D. Okay, low resistance postprandial. And that's because, well, obviously, we've had something to eat. We now have food in our stomach, in our duodenum, especially, and in the small intestines. There's vasodilation of the small arteries feeding the intestines. And of course, those small arteries come from the SMA and the IMA for the most part. And so when those vasodilate, blood flow is going to increase. Our peak systolic velocity is going to increase, and our end diastolic velocity is definitely going to increase. So there's a big difference in end diastolic velocity. So let's see, that's postprandial, and this is preprandial up here. If we look over on the celiac trunk, and really we could say celiac trunk, common hepatic, splenic artery, they're all going to be similar because, well, they're feeding similar things. Now, the common hepatic does actually, as this comes down, that's, of course, that's the GVA, right? This is actually feeding intestines, I'll just say GI tract. It's feeding GI tract down here, so there will be a change between pre and postprandial there. But for the most part, we're feeding liver and spleen. And of course, yes, there's actually an artery going up this way. That's the left gastric artery, and that also is considered GI. So I'm not saying this is a, you know, you got these guys and they only feed the liver and spleen, and then the SMA over here only feeds, well, there are collateral flow between all this stuff, and there are little branches. And that's part of what makes us, let's see, it makes the human body resilient, but it also makes our job harder. Okay, let me get on with this. The spectral on the celiac trunk, oh, I should also give you some velocity. No, I got that. The celiac trunk, common hepatic artery, splenic artery, they're all going to look similar. They're going to be low resistance from the start. Low resistance, even in the NPO state. And after eating, it's simple. Let's do, I'll fit an NPO here. And then I'm going to put an NPO with an X mark through it, meaning not NPO. And I'm going to say even lower resistance. Basically, all I'm saying is that the SMA and the CT are gonna look a little different. One difference there, or one anatomical difference, is when you have a common trunk of the SMA and the celiac trunk. Sometimes they come from a common source. Obviously, that's going to make changes, but we don't talk about the outliers. That's doesn't happen every day. You don't see that every day. IMA. Oh, you know what? I don't need to draw anything else. We're going to put SMA/IMA here. Reason being, both of these are doing the same exact thing. One's just feeding the right side of the intestines, the other feeding the left side of the intestines. The SMA is a little bit bigger. Well, it's definitely bigger, and it's feeding a little bit more than the IMA. So it has different velocity parameters, but the waveform is going to be the same. IMA is going to start off high resistance, and then you feed the patient, and it'll go to low resistance. So IMA, SMA are very similar here. I also have I have a really short PowerPoint today, guys, to go through. Okay, I'm going to erase this, but I just, this color here, that darker red, seen by ultrasound. In other words, we can see this. The more of the pinky salmon color, not seen by ultrasound. So just because we draw it doesn't mean we have a prayer in seeing some of these things. They could be, oh well, different layer. Hold on there. Well, let me get rid of that just so we can. Okay, so once again, we have our, well, I did draw on the left gastric artery here. Oh, you know what? And I had originally planned on connecting it. So let's just really quickly, just because I get a little anal about my drawings here. How am I going to connect that though? The left gastric artery comes back around. All right. This person's just going to have a little bit of an anatomic variant. Okay. Oh, that's horrible. This is what happens when I don't pre-plan. Okay. In fact, I'm going to erase this, but left gastric artery, that's going to come around. It's actually going to come and meet up eventually with the GDA. That's just ugly. Okay. So let's see. I'll just go ahead and gastroduodenal artery. I could have, you know, and remember, right around here is where we see the little circle in the head of the pancreas. I didn't draw that in. And that would be one tiny spot where you could actually see the GDA, but not really a spot where we could Doppler. Let's see, common hepatic artery, splenic artery here. I'm just going to say hepatic artery. I could do hepatic artery proper, but we'll just call it hepatic artery. You notice I made it pink between the common and the hepatic. Well, why? The duodenum. Duodenum's coming around this way. Stomach is up here. We don't see through the stomach. We don't see the duodenum through the duodenum. So very often, this whole area is off limits for ultrasound. Of course, we have our SMA down here and IMA over here as well. And oh, that's right. I suddenly thought of, like, why did I draw this? The reason I drew this out is two reasons. One, I wanted to show you our limitations. Where we can image. We can image as the hepatic artery is going into the liver. It's actually really hard to do because it's sitting on top of a portal vein, which is traveling in the same direction. So they're both red, and the hepatic artery is much smaller than the portal vein. So it can actually be very difficult to get the hepatic artery right there, but not impossible, and we should be able to do it. We can image dead center in the epigastrium here, typically transverse if you're going to want, well, any of these, the celiac trunk here, celiac trunk, common hepatic artery, splenic artery, we can get all in here. Here we're going to go sagittal, but we could get this area maybe a little farther, maybe not. This guy kind of runs on top of a lot of things, so it's not too deep in the body. We're able to see the superior mesenteric artery for a while. This guy, difficult. You know, we're going to have to do some pushing on the belly on some people in order to literally push gases out of the way and push intestines out of the way. And the harder you push, one thing we're going to learn in lab, guys, you can go ahead, the epigastrium all the way down, push without being ridiculous, but you could pretty much push as hard as you want. Unless the patient is specifically in pain in that area, it's going to be okay. Rib cages, not so much. You don't want to be pushing on rib cages, and you certainly don't want to be playing their ribs like a xylophone. But I wanted to show you that. I also wanted to show you why this is so difficult to do. Let's see, if I have a stenosis here, and let's say the stomach is laying over here. Let's actually, there we go, make that stenosis more just the celiac trunk here. If I have a stenosis here, well, we got a problem. We don't have any blood going to the liver or the spleen, right? Well, no, we have blood. We have, let's see, we have this artery. Looks like this, I don't even know what this artery is called. I think it does have a name, and I don't care what that name is, part of the GDA system. But in any case, the SMA is feeding this artery. And normally, you know, it goes one way, it goes the other way. It really depends. With all the interlacing of arteries, it's hard to say, you know, which artery has more pressure behind it. But I could tell you what, if there is a stenosis up here, well, now this artery is going to come around and backfeed the GDA and backfeed the common hepatic artery. So now the common hepatic artery will be going backwards, and it'll go across and feed the splenic artery. And of course, some of that blood will also head up to the liver. Now, if you could see this artery, and if you can see it, there's probably a problem because we normally wouldn't see it. It might grow in size. If it grows in size, well, if it simply grows in size, it's compensatory hypertrophy. So compensatory. I think it is. Yeah, it's compensatory hypertrophy, but it is hypertrophy, but we're going to say compensatory flow. In other words, this guy is going to become bigger. The velocity is going to be faster because now whatever this artery is now going to be feeding the entire liver, the entire spleen, heck, the left gastric artery as well. It's all going to be fed from that artery. So that's compensatory flow, or it's compensatory hypertrophy. It's compensatory flow, but it's also maybe called a collateral. Collateral flow, it just simply means I-10 has an accident. You're forced to get off the road. Now you're going to take some, you know, one of the other roads, going to go through a smaller road in order to get around the accident. Well, that's exactly what happens in the arterial system. So this became our main highway to get back to, well, that's right, the west side and the east side of town. Okay, so that's, why didn't I use a layer? All right, let's start using layers. The other connections would be, well, another big connection is this guy coming around here. Arrows going both ways because the SMA comes around to the right side of the body. It kind of follows that colon and the transverse colon, and the IMA does the same thing on the left, and that comes up, and somewhere they believe the flow kind of stops crossing over right about that point. But obviously, if I have now a stenosis here, well, we might have compensatory hypertrophy, compensatory flow, collateral flow from the IMA, and what could end out happening is now we have flow going around and feeding what should have been fed by the SMA all through the IMA. So if you find a very prominent IMA, that's an indication that your SMA has a problem somewhere. And that could be, by the way, the most common location for stenosis, for plaque buildup, is right at the beginning of these arteries. But common doesn't mean the only location. Obviously, at the SMA, we could have stenosis here. We could have a stenosis here, all the way down here. It's, you know, so we follow as far as we can with both of these vessels, well, all of these vessels. The SMA, you'll be able to follow for quite a few centimeters. The IMA, you will not be able to. So what are the things we look for? We can see color bruit. I forgot to get a picture of that. Well, a color bruit is when you put Doppler on an artery. Let's say I have a Doppler box right here on the splenic artery, and there's a difference between having your PRF too low, which will give you a lot of aliasing, your color gain too high, which will give you a lot of spillover. If you have your settings correct and you still have, why aren't you red? You still have all this confetti on the outside. Let's do a nice little blue. If it doesn't, it's not here or there. When you have all this confetti on the outside, you could be looking at a color bruit. That simply means that as blood is traveling through a stenosis, sorry, I'm over here on the edge, guys, rumbling through that stenosis, causing all sorts of turbulence, it's going to shake the tissue around it and cause a color bruit. Sorry, I was just reading comments there. Well, and of course, aliasing, like I said before, if there's no aliasing, then there's aliasing, and then there's no aliasing, that is an indication of the stenosis itself. And of course, with spectral, you'll see the velocity change. Retrograde flow, we mentioned that right here. That is called retrograde. Retrograde, it just simply means backwards flow. I know for the liver, we call it hepatopedal versus hepatofugal. They could just call it retrograde and make it a lot easier for everyone, but they don't. Retrograde is sorry, I just changed position and I apparently can't write position. Let's see, I mentioned compensatory flow. Oh my God. Yeah, it's gonna be a really short one today, guys. That's what she said. Let's see, where do I have room? I guess I have room up here. Do a little bit of writing. When we have grafts and stents, I got, you know what, I have a PowerPoint, and then I have another PowerPoint. I'm just going to pull it up really fast. Both of them are just pictures, and neither one of them will take long at all to go through. And that'll help us with grafts and stents. I actually, I had a really hard time finding graft and stent images of mesenteric arteries. I found plenty for, you know, the aorta, and you've already seen some of those images. So, but okay, let's talk about the actual exam. So I had one. This one's coming to mind. I was working in a small office. That's when I had my own business, and I'd go down to this town way south of where I lived, out in the country. And, I had a lady come in, and the doctor heard a bruit. Yes, heard a bruit. And he heard it right dead center in the epigastrium. And so I went in, and sure enough, her SMA. Well, let's see. I checked her aorta, and that looked okay. But then her I looked at her SMA, and sure enough, that had a stenosis in it, and that was causing a color bruit. It was causing aliasing because of velocity increase. There's no retrograde flow. That was something different. It's only a stenosis. Yeah, I mean, I was really impressed that the doctor found that. I think he actually even felt it, which would make it a thrill. But in any case, the doctor found that and asked me to look for it, and sure enough, I found it. Which is I forgot which organization, says that at a minimum, a mesenteric artery exam should include the aorta, the SMA. Celiac, well, that's right, I have CA down here, but I'm going to put CT, celiac trunk. I prefer that. You know what, here with this. Celiac trunk or celiac axis. Choose your favorite. Common hepatic artery. Surprisingly, not the splenic. Not initially, anyway. SMA. I'm sorry, I did this slightly out of order. Here, in fact, let me just do something. I'm going to put it back in order. Of course, for you writing it down, I'm sorry. So aorta, celiac trunk, common hepatic artery. For now, we're just going to skip the splenic artery, and we're going to do SMA, and it says proximal and origin. That sounds like the same thing, and it kind of is. I'm going to write origin first. When they say origin, they mean not here, this is proximal. Origin is the origin, right there. So SMA origin, and then proximal. IMA. And that's at a minimum, that's all it's needed. And then we have a recommended, so a few more arteries, which I would recommend too, actually, while you're there, you might as well do the splenic. Here, I'm going to put plus for things you could add on to the minimum. Splenic, and then back to the SMA. Here, I'll put a plus sign up here. Plus mid to distal. In other words, just try harder. That's all they're asking for that SMA. And let's see, what was the other one? Oh, and then also, they suggest just taking a look at the SMV. Now that's V for vein, and IVC. Of course, if the SMV is thrombosed, it's going to have a very similar symptom for the patient as a plaqued or stenosed SMA. If you can't get blood in, you can't get blood out. as far as your symptoms go, they're going to be pretty similar. So they strongly suggest that as well. I know a little bit about billing. I think anytime you do an arterial study, you should do the veins as well. Because when you add veins, you're doing a little bit better job of getting money in. And, obviously we want to, the point here is to do good by the patient. And the point here is not to soak the patient, but it's also to make a living. And Doppler studies are not Doppler studies if you're only looking at the artery. Oftentimes, I'm not a total expert on the rules there, but it's always a good idea if you're looking at the artery going into something, look at the vein coming out and make note of it, because you want to get paid. And trust me, if I find out that you're not getting paid, or the hospital's not getting paid, you'll hear about it. Okay, so what does this mean? So let me just make sure that we all understand what we're talking about here. So when I say aorta, well, we're going to do, let's get my straight lines here as much as we can. We're going to Doppler, spectral, and color Doppler, proximal, mid, distal. It's always a good idea to do proximal, mid, distal whenever possible. Celiac trunk is typically so short that you're only going to do one on that. It's kind of, I'll do one more or less at the origin there. Common hepatic artery, you're probably only going to find one location for that. So your common hepatic artery out there. Let's see, superior mesenteric artery. This was transverse. We're going to go back to sagittal and probably walk it through. Ah, that's right. I want to do that. Walk. When they say walk, that means you are taking your region of interest and you're sliding it along. And if you could do that on a frozen picture, you could probably move it a couple of centimeters and still stay inside of the artery. And then you might have to unfreeze your image, figure out where you're at, freeze your image, and slide this along. And so while you're sliding, you're not just looking at one single point, you're looking at a multitude of points, and you're just waiting for something to happen. It's going, it's like, when you hear that, you've slid into something significant. So that's what we mean by walking through the area of interest with your region of interest. If that makes any sense. From origin to proximal, and origin and proximal for sure. If you have a nice, beautiful color Doppler of the rest of this and there's no aliasing, if your doctor wants you to do it, you do it. But if you're seeing it beautifully, no color, no aliasing, then you might be wasting your time walking your way all the way through. Let's see, so we've done our SMA, we go back and do our IMA. Your book says go transverse. So transverse, you start off on maybe right at the bifurcation here. Remember, like the carotid bifurcation, there's a bifurcation right there of the iliac arteries. So you could start off in the bifurcation and then work your way back uphill, back cephalad, until you find this. The problem is, I find on a transverse image, this does not show up. It doesn't show up in grayscale typically. And on color, well, we know that color in transverse is unreliable. And so personally, I like to go sagittal just a centimeter or two from the bifurcation. I go sagittal and I just slowly move off to the patient's left because that's the way it's going. And I tend to find it that way, but we'll work on that in lab. And then as far as the, let's say we'll call this anything that's plus down here, we'll call that the enhanced exam, and the splenic artery, you know, you could obviously do that as well. The superior mesenteric vein and the IVC, you could take a look at those, make sure there's no thrombus in there. And then we're good. Oh, no, I think I have velocities on my, let's see, what time is it, 1:43. Now we're just gonna work through it, guys, because we're gonna let you go early today. Let you go early. Okay. Oh, man, I ended out on the, slideshow right there. Sorry. Jumping from one technology to the next. I can't think here. Okay.
When you're talking about the aorta and the images that you would get from that, I noticed you said color Doppler and spectral Doppler, but you didn't say anything about grayscale. Do you get all your information from the color?
I would always take a grayscale image as well. Yeah, I mean, I would always take a grayscale image just to show what you're looking at, because you might see it in grayscale. So yeah. Let's see. Let me grab my. That's so funny. Once it's there, I cannot get rid of it. Really. Oh, I need another setup. Okay. I need my other set of controllers. I'm not going to worry about it. Okay. So I figured I'd show you some images. This top image up here, well, this stays on the, okay, yeah, it stays on the screen so I could draw all over. That's good. Or stays on the slide, I should say. Top image up here shows the seagull sign. Both of the arteries coming off of it are blue. It's kind of interesting. This one over here is just barely blue. I think it's at that 90-degree angle. It doesn't quite know whether it wants to be red or blue. And this one certainly wants to be blue here. Remember, it dives down because that's where the spleen is. Spleen's down here somewhere. Doesn't seem like it would be, but it is. Seeing as how the liver's up here, why wouldn't the spleen be up there? And red, I got a little bit of aliasing right here, but let's see, what's their velocity? 100, it doesn't say, 120, that's what, 100, let's just say it's like 130 centimeters per second. Well, the celiac access is pretty fast, and this is normal. Well, actually, we also know it's normal because we have a nice open window here. Not always terribly reliable. Sometimes you just get a bad angle. Like this is a normal velocity down here. We don't have much of a window. But transverse view, sometimes on the celiac artery, a transverse view is the best for you. Sometimes a sagittal view. On this person, their artery is laying down. That's a normal, it's not even a variant, it's just normal. It lays down. You're gonna wanna go sagittal on this artery. This artery looks like it's standing straight up. Well, I guess with standing straight up, it doesn't matter if you're sagittal or transverse, but it just wouldn't matter if it stands up. So, and anyway, celiac trunk, low resistance, feeds liver and spleen mostly. Does as it has branches that feed the GI tract too. You may, when you're looking at this, you may find plaque stenosis or plaque occlusion. Peak systolic velocity of greater than 200 centimeters per second relates to a, I think it's equal to, no, I don't know what you just did. Greater than or equal to 70% stenosis. So when this velocity reaches up to here, now we're talking about stenosis. That's pretty close. I wonder if there's a slight stenosis here, but like I said, though, the celiac trunk's difficult because it's kind of a fast artery to begin with. You may find malls. Oh, you know, I do have images of malls. I know I've already told you this, but I had a student with malls last time we went through this. It was awesome. It was awesome, you know, for me. Let's see. Okay, so celiac trunk, and that's pretty much all you're going to do. You're going to get some grayscale color. Just scan the same area. Okay, so let me. So I have a question. You know, why would the spectral show different waveforms for the same area? And I assume not only the same. The question is not only the same area, but the same exact vessel. So if I start off preprandial, NPO, hungry. Well, let's answer that question not on the celiac axis, though. I'm going to answer that question in just a second. Let me just get to median arcuate ligament. Yeah, I'll get back to that. All right, median arcuate ligament syndrome. Now, this ligament is really the very bottom. You know, they call it a ligament. It's almost more tendon, you'd think, because it connects. It's part of the connection of the diaphragm to the spine. It crosses in a way over the aorta. And paradoxically, in other words, kind of weirdly, the compression of the celiac trunk by the median arcuate ligament occurs with expiration. Yes, and I call that paradoxical because when we take a breath in, your diaphragm goes down. You would think the diaphragm moving down is what would cause the median arcuate ligament to move down and impinge on the celiac trunk. It's not that way. It's actually when we, it's not when we inspire, when we take a breath in, it's when we expire. We relax. And the relaxation of the diaphragm is what causes the median arcuate ligament to slide down ever so slightly. The syndrome occurs mainly in thin women, and yep, my student was a thin woman. She has no symptoms, although she definitely has the syndrome. But you know, it can be right upper quadrant discomfort, basically because every time you take a breath, you're reducing the blood pressure going to the liver and the spleen, which is not good. A bruit may be heard on examination by the doctor. So this is inspiration here, and the celiac axis is wide open. Expiration, you could see the celiac axis is being indented by something invisible. That it's oftentimes not so invisible. It's usually hypoechoic, but it's kind of draw, and there's that ligament coming down, indenting on that. Same thing up here, except they have a backwards inspiration on the left, normal flow, and then suddenly it's cut off. Why we're not seeing aliasing is beyond me. it seems like there should be massive amounts of aliasing right here because it is being, once again, being indented upon by the median arcuate ligament there. And here we have high, that is the right one, yeah. High velocity flow, let's see, 600 centimeters per second end diastole, about 250, 225 centimeters per second in end diastole here, and peak systole up there. So that's definitely, and very turbulent flow. Not only do we see the turbulence in a closed window down here, but you also can actually see the, you see that fuzziness on top also shows turbulence. That's median arcuate ligament syndrome. Let me just get through hepatic artery and then I'll answer that question. Hepatic artery, so the common, here's a nice celiac trunk. You see that this trunk just kind of curves to, this is a transverse view, of course, curves to the patient's right. That's normal. Sometimes it does that. And so common hepatic artery going to the liver, splenic artery going down to the spleen. The celiac trunk, splenic artery, and hepatic artery will all have similar waveforms. Low resistance, even when the patient is hungry, because the spleen and the liver are always working. Not that this doesn't change, but it with food, but it's low resistance from the start. We already mentioned this. Reversal of flow may indicate an occluded celiac trunk. So I drew that earlier. But you see here, this is you know, just a normal looking hepatic artery waveform here. Another nice picture. Oh, look at that. Yeah, right there. That's the left gastric artery. At least I'm getting angry with you. Okay. I wanted to show, I just grabbed this picture. It doesn't really have anything to do with anything other than, here's the, remember how I said the arteries, what? Literally, I have no idea. The artery splits into right and left, and you know, this is the left, this is the right, and the, let's see, portal vein continues on, and that splits too. But then I'm going to go over here. This is the common bile duct. Goes over the right hepatic artery, and then that splits. They all split together. They just don't split exactly at the same time. So, and I just found out too that the sign is actually, I never knew this, the sign is called the inchworm, the inchworm sign. You know, inchworms kind of go, as they're moving along, they inch along like that. Oh my God. I hate you. Whatever this program's doing. And then here's our artery there. So this person, they have their artery on top. So instead of this configuration, they have an artery. Oh, wow, that's really bad. Okay, well, the artery is on top of the common bile duct. So this is CBD here. That's a portal here. And that's the right hepatic artery. The book, yeah, I think it was the book read that this is a replaced hepatic artery. And so it drove me nuts. I did research it. No, it might be replaced. It might be normal. Now remember, a replaced hepatic artery simply means an artery that didn't begin here like it's supposed to. All right. I had a student last semester who had their entire hepatic artery, their common hepatic artery, because sometimes it's just the right Their hepatic artery proper started here. Well, that's still a replaced hepatic artery. Sometimes it's the right hepatic artery that does something funny here. But in any case, I am going down a rabbit hole. Let me get out of this rabbit hole. And before I forget, let's talk about this again. So normally a high velocity artery, so be careful not to, oh no, never mind. High resistance. This is a high resistance artery right now. This person, guarantee you, is NPO. They're hungry. Ah, look at that. I didn't even see that. Fasted. Okay. I think what the question I received is why, how could it change? Well, this artery is feeding the GI tract. I can't write with this, so I'm going to keep it as minimal as possible. The GI tract. When the GI tract is not digesting anything, it does not need extra blood. So it sits there just kind of resting, waiting for its next meal. It tells the arterioles around it, the little tiny arteries feeding it, it says, hey, you know what? Don't worry about it. I don't need the blood. As soon as food goes into the GI, and this happens very quickly, the GI says, oh, now I want that blood. Now I want that blood. So can you give that to me? And what it does, it actually sends a chemical, a chemical transmitter, basically, almost like a neurotransmitter that goes from the GI tract, a hormone, basically, that goes from the GI tract to the arterioles. The arterioles get the message, oh, okay, now I'm going to open up wide, let all the blood through, so now the GI can better digest. So when that happens, your artery does this. It actually goes a little faster overall. Oh, I hate this program. The overall velocity, the peak systolic velocity increases. Can't erase. Peak systolic velocity increases. And end diastolic velocity increases even more. Not more than peak systolic velocity, but the percent increase from 0 or close to 0 is more overall. So hopefully that answers your question. SMA, normally a high velocity artery. So normally a high velocity artery, so be careful not to overcall stenosis. In other words, finding a velocity of, let's say, 200, 225 in the SMA, that could be normal. And also depends on their NPO status. If the patient didn't know to be NPO and they snuck some food in, then their velocities will be higher. Patient is often symptom-free because of collateral flow pathways are abundant. So if we have a stenosis here, or even a blockage here on the SMA, well, you had an IMA down here. Please stop. You have an IMA down here that could be backfeeding the SMA. So patient is oftentimes symptom-free. Here's our IMA. Great pictures, because this is exactly what you see. That's about as much as you're going to get on a sagittal view anterior to the aorta. And what this person did here is they, let's see, aorta. I would say they're sagittal oblique, because what happens is, let's say they're perfectly transverse. Aorta is here. And what will happen is that the IMA will turn to the patient's left really quickly. They could be transverse, they could be a little oblique, doesn't matter. That's about as much as you're ever going to see of the IMA. Let's see, harder to find, but nothing a little push down won't help. In other words, don't be afraid to push down on your patient's bellies. Only see a short segment, a similar Doppler characteristics to the SMA. However, research is lacking. We don't have a lot of info. In fact, the book didn't even provide info on a 70% stenosis. The book was providing other info, other arteries for 70%. Instead, it just said 200 relates to a greater than 50% stenosis. So not as much research. I threw this one in here simply because this is angiography. And what they're able to do is, here's, see a little stent coming up right here, probably coming up through, looks like it's coming through the right femoral artery or iliac artery. In other words, they went through the inner thigh, popped a hole, put the stent up, and dropped some dye in. And look what happened to that dye. It fed the, let's see, rectum, sigmoid colon, descending colon, and just a little bit of that transverse colon. And I don't know what they're pointing to over here. Yeah, but that's pretty cool. That's a really cool image. It shows how the IMA feeds the left-hand side of the body, and this really is. This is pretty much just colon. I'm surprised there's not other intestines getting fed there as well. And that, guys, is it. Oh no, it's not it. Let me pull up that other PowerPoint, because I started doing graphs and I'm like, you know what, I got better graphed images. But this is obviously you know, a little bit of PVC put in the body here. These are actually the reason why this is all open is because this is aneurysm repair, the AAA repair. But in the process of repairing it, they've also put in grafts going to different organs. Let's see. This one down here. God, I don't know. Oh, you know what? I do have it. Hold on. Different configurations of renal and visceral arteries rerouting during a hybrid AAA repair. Wide graft repair, mesenteric artery and celiac trunk. Oh, wow. So SMA would normally be up here, but they've just kind of plugged in a graft here, and they're bringing it all the way back up to feed. And of course, part of the problem that makes this difficult to understand is that they've taken all the intestines and they've literally pulled them up and out of the way. And so we're seeing this pulled up and out of the way, but this is kind of, this looks like it might be a replaced SMA, and this might be replaced IMA on this one, and I don't know. These get too confusing. Let me pull out this other. Grafts and bypasses, there we go. Okay. So just bear with me, guys. We're going to go through this real quick, and we will be done. Grafts and bypasses. Strengthening a road, creating a bypass. Surgeons are like city planners. This is an endograft, meaning it goes inside a existing artery. In this case, this person had, no doubt, had AAA. Was placed to fix an aneurysm that involved both iliacs and the infrarenal. There's your renal, so infrarenal is below. And both iliacs had some stuff going on. This person has to have contrast put into their body in order to see this. In other words, the rest of their body, and these are kidneys, that filled up with a little bit of contrast, but the rest of their body was subtracted, digitally subtracted. So all we see is really the blood and the contrast in. Here's a single artery going to the kidneys. We're also obviously seeing the meshwork of the graft itself. On the outside of the vessel, it is. Oh, okay. The graft appears to be on the outside of the vessel. I'm like, that's not right, but it is not. The walls of the arteries are seen within this filter setting. In other words, this is, you subtracted all the tissue to get that picture. Endograft placement. You put the stent up here, and then this graft is, as this tube is removed, this plastic tube is removed, this wire automatically opens up, and you create the stent here, and then you actually sew in a second stent if you need to do both iliac arteries. There's just, and an endoleak here. We mentioned this is, I know this is a couple weeks ago, but so here's what was remains of the aneurysm. There is the stent is already gone into left and right, and then there's a endoleak. Who knows exactly where this endoleak is coming from, but it looks like it might be coming from a backwards flowing artery, flowing backwards into what's left of the aneurysm. Open surgery is still a viable option depending on the patient. So I actually normally kind of hold off some of these pictures until peripheral vascular, because this is crazy. Let's see. It's typical axiobifemoral femoral, in other words, a fem, sometimes called, is typically undertaken when there is a significant aortic occlusion or bilateral iliac occlusion in a patient not fit or suitable for aortic surgeries. Because aortic surgery is a wide, you split that patient wide open. And let's see. I don't understand the first picture. It looks fine. But the second picture, I think we have a significant stenosis right here. And so what they've done is they've taken a little bit of PVC. They've gone from the axillary artery, or all the way up near very close to the armpit. And this is just under the skin. So if you were to see this person, they would have a tube running underneath their skin. Comes all the way down, fall out of the way, and feeds the right iliac artery, or the right, actually, femoral artery. Now, sometimes they'll do is have another bypass, but it depends on what they need. Let's see here. Let's look at the next picture. Yeah, there's our fem. And this is pretty cool. This is their cell phone. No, it's not a cell phone. It's just you see various clips and everything. But in any case, this is a crossover fem bypass. This patient also has a aortic bilateral endograft as well. Yeah, so they have an endograft. This person's all messed up. An endograft like we looked at before, and then they took a little bit of corrugated tubing. This goes from, femoral artery up through their pelvis and back down to the other femoral artery, because why? One of these arteries up here has to be, there's something wrong, because we're pulling blood across to feed both legs, and I don't necessarily know which direction this is going, but it's definitely going. They wouldn't put this in there for the fun of it. So something failed on one of these sides here. It's kind of cool. This patient had previously had a no longer open, no longer patent, and on the right, a patent Dacron graft. So on the left, you can see, not very clearly, I see it down here a little bit more. And the reason this doesn't show up as well is because, well, there's no contrast in it. And it's not the density needed for this particular showing. But it used to be on the left-hand side, blood would come down, go down the leg this way, and then cross over and go down this leg. Well, that, itchy nose. This is no longer patent, so then they had to do it again. And they said, well, forget the polytetrafluoroethylene. Yeah, nailed it. We're going to do this one, the Dacron. And this one comes down to here, crosses over, and crosses over there. And you can see what's left of the aorta. Actually, the aorta, oh, that's SMA here. This little thin little line, that's the superior mesenteric artery, the renal arteries, and the aorta just ends. There is no aorta, or for that matter, iliac arteries. There's just a little bit here and here. That doesn't mean that the aorta is literally missing. It's missing from this image because there's no contrast in it, meaning there's a total blockage of the aorta. And these are obviously computer-generated reconstructions. This over here is the actual CT image. That's very cool. If anyone wants to type in their guess as to what this is. Let's see what's. Okay, hint number one, the patient did not win a hot dog eating contest. Good, John Paul, that it is intestines. It's not normal. This person, let's see, do I have the answer here? This patient is now in jail. That's hint number two. Oh, that's right, I have notes on it. This image represents a 3D reconstruction of an abdominal CT scan taken of a cocaine smuggler who presented to the emergency room with absent defecation for 2 days. So they created a whole bunch of packets for this guy to swallow. And I assume he swallowed them. He could have gone the other direction too. But let's see. Just so you know, not everyone's transverse colon goes straight across. It is sometimes goes up, down, and like almost like a bandolero gun sheath here, or bullet belt going across like that. It kind of goes across and then back down. So yeah, it's a bunch of stuff in the intestines. And here's a actual image. You can see up top. Yeah, these are all packages. Each one's a package of cocaine. Good thing none of them's opened up. You can see this kind of little nasty end up here. See a little tiny spikes. Those spikes bury into the aortic wall, and that's what grabs onto the aorta, and then yeah, and there's those spikes up there going up in there. This person has a graft, and these other renal grafts were even made, sewn in after the fact. And oh, this picture, is that it? Yeah, that was the last picture. This one's very hard to understand, mostly because it's laying on its side. And no, this is not a loogie. This is an actual image. The body, all the tissue has been subtracted. There's a little bit of kidney. This person has only one kidney. A little bit of spleen. But that's only because some of the contrast got into the kidney and the spleen, and a little bit in the heart muscle here. That's the only reason why we're seeing that. The rest of the tissue has been subtracted. Aortic arch, person's, subclavian, axillary. It looks like their arms might have been up here, and so here's our carotid system, internal carotid. Oh, I'm sorry, vertebral artery, internal and external carotid over here. That's kind of cool. And we come around. Oh, these are pulmonary arteries. Those are cool. Going out to the lungs, and let's see, we're going to go in. And this is not toothpaste. This is a endograft. It's just the computer signed that density a certain color. Oh, it is signed the metal, this color, this density, that color. Look at that. Well, that's not metal up here. This is plaque all up here. It just happens to have the same density or close enough density where the computer gave it the same color. And then, we have this weird thing laying down on top of the aorta with hoses coming out. Very strange. Well, I thought I had an image. I actually found another image of what this is. I actually found a surgery image. I don't think I kept it. So this is kind of like I think a side-by-side graft. And this is going off and feeding. Let's see, it's coming up and feeding. Well, the celiac trunk. We have another one feeding SMA. And this one's feeding the renal artery to the left kidney. As we go further down, we find more plaque. Exterior iliac artery, internal iliac artery. So this is where the iliac artery split into external and internal. As it comes, God, this person's so contorted. As this person comes up, femoral artery starts right about here. And we know that because once it starts to branch, then we're clearly into the femoral artery. But let's see, 220. Okay. Oh, how did I? Oh, that's weird. I just rolled straight into the other PowerPoint. Okay, guys. So make sure. Looks like I have to reset someone's homework. I don't know how, but I will. So there, you do have homework today. I'm going to have to create. I'll create more homework for tomorrow. I'm going to try to keep it to 1 or 2 questions, three or four, maybe 5. But I want to keep it. Useful, but not too much on a daily basis. So I'll build those out. But you do have 2 homeworks, one in class, and then one for the lab for this class, so 200 and 205. Due by midnight tonight. A week from now, we'll either do renal artery stenosis or not. I'll decide on that. But in any case, questions, comments?